So can you just take me a little bit through what actually happens when there is a major disaster from the, from a nurse's perspective?
Yep.
How does it actually work? How, through bringing the people into the hospital, what happens?
Yep. So I'd start by saying, nationally, if we think about the definition disaster, from a health perspective, it normally means that we don't have enough resources available for people to survive, which means that as a result of the disaster, people will unfortunately die. In Australia, we haven't really seen that at a national level. So there really hasn't been a disaster where we've turned around and not had the resources to save people. So I'll take Victorian bushfires as an example of that. So from a national level, they cleared out trauma centres. In terms of moving patients out of trauma centres into other parts of the hospitals, the intensive care units and the burns units, they moved patients that were stable out of those units to prepare for an influx of patients with critical illnesses and burns and so on. Those centres never got filled up because people in those types of disasters either died or had minor injuries or illnesses. So from a national perspective, it wasn't really a disaster, right? If you drill down though to the state, and in particular once you get to the community level, it most certainly was a disaster. The people in the community at that particular time would have been overwhelmed and stretched, and they would have been making decisions about whether someone would die or live on a split-second moment. So at a community level, disasters happen. So if the disaster happened in an area where you have an emergency department, as I said, the first patients that present are likely to come by their own private means, not necessarily part of the disaster officially. At some point in time, the government will announce that a disaster has happened, and internally the hospitals have processes around that. We have different codes, and you would have heard about codes from TV shows and stuff. So if someone has a medical emergency, it's a code blue. If there's an external disaster to the hospital, it's a code brown. And an internal disaster is a code yellow. So we have all these different codes which we use, which are colour-coded in hospitals. Essentially, it just means there's an ability to identify when our resources are overwhelmed. So an example of that recently would be the asthma thunderstorm in Victoria, where the hospitals were overwhelmed and they called it a disaster, meaning they didn't have enough resources in their emergency department to cope. Means they need to change the way in which they do their normal business. So if we're in an area where a disaster happens, patients start to present. Depends on the types of patients that we see. Again, whether it's from bushfire flood type things or whether it's something more radiologically, chemical, nuclear, or unknown substances, because the response is slightly different. They're based on the same premise. The overarching premise is do the greatest good for the greatest number of people, which normally means if your patient arrives and they're having cardiac arrest and you're doing CPR on them, for example, in a hospital on a normal day, and that would happen on a normal day, that there may be 2 or 3 doctors, there might be 4 or 5 nurses, all assisting that one patient. Well, in a disaster, you're not going to have the resources to do that, which means you need to make decisions about whether or not that person needs 6, 7, 8, 9 staff members, or whether or not you're better off having those 6, 7, 8, 9 staff members out helping 7, 8 or 9 people. So there's a thing called reverse triage, which we do in a disaster in that circumstance. So the patient will normally present, see the nurse as the first point of contact in most hospitals, emergency departments. The nurse will undertake a process of triage to determine the priorities of care. Who gets seen first, who gets seen last. Normally the walking wounded will all get put in a place together. They can wait for as long as need be. They could wait for tomorrow and still are going to be okay. And then normally you get into 2 more larger groups. Those patients that are going to die imminently if you don't do care, and they're the ones that you need to make decisions about whether you put resources into assist them or not. And then those groups of patients that you need to do stuff now and are likely to survive. So on a normal day-to-day basis, we'd probably start with the people who are imminently going to die and try to save them, but in a disaster, we probably wouldn't. In the emergency department itself, the operations are slightly different. The idea is to try and get as many people out of the emergency department as possible. So if they have mild ailments or injuries, it's try to move them elsewhere, whether that be discharge them home, tell people to come back in a few days' time, go see your GP, or move them to the ward if they're meant to be admitted to the hospital. Some of the challenges in the emergency department, as you probably know from the media, is that they're always full, they're always overflowing, there's normally ambulances lined up in the corridors, so it's a logistical nightmare to try and solve. Whereabouts are we going to put all of these people in a disaster, and whereabouts are we going to put the people that are currently in the emergency department, either those people that need to go to the wards. Some people are still in the workup of determining what's wrong with them in terms of their injuries or illnesses, and some people haven't even made it into the emergency department itself to work that out. So we have this normal day-to-day capacity, 90 to 100% capacity within the emergency department or more. Then on top of that, now, the disaster on top. So the logistics are, the principles are greatest good for the greatest number, so we try to get people out of the emergency department that don't need to be there. We try to get the right staff into the emergency department at the right time, knowing that if a disaster lasts for multiple days, we don't want all the staff there at the same time because they'll just get exhausted and overwhelmed and we won't be able to maintain our capacity to care for people. And then it's about trying to determine which patients you see when. So it might be about segregating different groups of patients into different areas and seeing this group first, this group second, this group third. How you keep track of those patients. There's some technological innovation around how you might do that. Currently, most of our health services will use paper to try and track people, whereas some other places use scanning of tags and tracking of people with numbers and so on in different ways.
Has there been much change in terms of, so you mentioned we still use paper, has there been much change in terms of adopting technology in the last 5-10 years?
Well, the short answer is yes, there has been much changed. The second part to that is, does it work? Probably not, because we need to remember about the issues of disaster in terms of infrastructure. So it means that power might not work, telephones and communications might not work. So sometimes when things start to not work, people just revert back to what they know does work, and that might be a piece of paper and a pen. Writing on people's limbs with Texter, for example. That's not going to, you're not going to lose that. So there's different things that people do around that. So perhaps now with technology in terms of, larger capacity for batteries and smaller devices and that type of stuff, sure, there may be capacity to do more around that now.
But that's a very valid point, is that, depending on the disaster, your technology might not work.
Correct. And we know that even just general day-to-day communications, you think about things like New Year's Eve at Sydney Harbour, and you try to send a text message to your mate across the other side of the country, they'll get it the next day because the telephone networks are just so jammed with people sending messages that the communication just slows right down. So we saw that around the Canberra bushfires 2003, albeit now quite some time ago, but you just couldn't text, phone. The only thing you could rely on was landline communication at that point in time. And that probably hasn't changed too dramatically, other than some communication infrastructure now has given priority to emergency service personnel and given priority to people in the community that are dependent on communication. So if you're at home and you're dependent on electricity to drive your oxygen concentrator, there's priority communication with you over other people in the community. So they're starting now to get some more of that infrastructure available. The question in the emergency department, though, is who starts to do some of the movement, who starts to do some of the work to move all of these people around whilst waiting for incoming patients at the same time. So in most hospitals we have orderly or wards people who normally take patients from the emergency department to the ward or the emergency department to medical imaging to have x-rays or scans done. So they're likely to be doing their normal function of trying to move people out, but again, they only have a limited number of them. Then if we add the complexity to it, that is, there might be a chemical, radiological, nuclear type of incident. What we normally do in those instances is set up a decontamination shower. So this is like a big tent, which we set up outside most emergency departments, which has water running through it continuously, where people can just walk through it and whatever chemicals that they have on them starts to wash away the chemicals. Prior to them actually entering the emergency department, and they become decontaminated at that point in time. Some of the challenges there are to set up these tents can take an hour. To set them up normally takes training. To set them up we normally train with nurses. but we know the nurses aren't going to be setting it up on the day. So the question is, who sets up these tents when a disaster happens? In Canberra it's cold in the winter, so we normally heat the water with boilers and so on, so that takes more time so people don't end up hypothermic as well as contaminated. The question is that takes longer. So some emergency departments, what they're doing now in their redesign is in their ambulance bay where they have like awnings, they're putting sprinkler systems in their awnings so that you essentially press a button, turn a tap and hoses happen and people can just walk underneath the awning to be decontaminated. So that's one solution. My solution is always maybe I'll just get out with the fire hose and hose people down as they walk through. Achieves the same thing, but you still need someone there to turn on the hose and hold the hose and so on and coordinate all of that. So
that's fascinating. How does it happen, you know, taking us outside of Australia and looking at things like Ebola in a third world country where the facilities are just really, really basic? How do you plan this type of thing, and what happens when we send over nurses and, you know, doctors to help out in those kind of situations?
So the first part is about the plan. So most hospitals have emergency plans. Well, every hospital has to have an emergency plan. That's going back to those codes and colours which I spoke about earlier on. It's normally a document this big. It's normally a document which is written by one person or a team of people, which is normally a small team of people. And if you were to walk into the hospital and ask a doctor or a nurse, a wards person, a clerk, to point out where the disaster manual is, I wouldn't know what the percentage is, but there'll be some people that wouldn't know where it is. Then if you ask the people that where is it and what would you do in a disaster, there'd be a group of people that wouldn't know what it says their role to be in a disaster. It's too big. What's needed is just in time. Most of this stuff is needed to be just in time training, just in time action around disasters. So instead of training people to be knowing how for all types of disasters, it's about teaching people the general awareness and principles of disasters and what your general role would be, and those broader concepts about, well, if you're a nurse in a disaster, your primary role is care for patients. In a disaster, you talk to this person, don't talk to these people, because that just makes for confusion in communication. And perhaps instead of a large manual, what we need is smaller cards almost that you just rip off and hand to the nurse and go, hey, here's your role description, this is what you do, this is who you talk to, this is where you get your equipment from, and so on. And then on the next shift, you just hand your card on to the next nurse that comes on.
So it sounds like communication is definitely an area where innovation or improvement would make a big difference.
Absolutely. Communication between healthcare providers, in the emergency department, between the hospitals, between those other agencies. Communication is fundamental to ensuring that the right patient is at the right place at the right time. And there's a lot of work that's happened around that in terms of normal patient flow through emergency departments on a normal day-to-day basis. But when it comes to a disaster, the best laid plan, it's a plan, it's not going to work. Plans don't work in disasters. As soon as you open up the plan's gone, you need a new plan. So it's more about how you problem solve, critically think and analyse on an ongoing basis through the disaster rather than referring back always to the plan. The plan needs to be much more simple and concept based.